Welcome to this Step 3 review on thyroid management, brought to you by Roadmap to Residency. Thyroid questions show up constantly, and they almost never ask you to recite physiology. They ask what you would do next in clinic. Our goal isn't to reteach the thyroid axis, it's to show you how these stems are built, which numbers matter, and which choices are traps. Keep your question bank open and a trusted review resource nearby. Let's get started. Here's the plan. First, how to read thyroid-stimulating hormone the way the test writer intends, because that single value tells you where the problem lives. Second, medication adjustment, both for the patient on hormone replacement and the patient on an anti-thyroid drug. Third, thyroid nodule follow-up, one of the most predictable algorithms on the exam. And throughout, full multiple-choice walkthroughs explaining why the right answer is right and every wrong answer is wrong. For the underlying content, lean on your question bank and your review resource. This video is about applying that knowledge when the clock is running. Our first strategy is to let the thyroid-stimulating hormone lead you. You're almost always given two numbers, the thyroid-stimulating hormone and the free thyroxine, and their relationship is the whole answer. When they move in opposite directions, one high and one low, the problem is in the gland itself. That's primary disease, the vast majority of what you'll see. When they move the same direction, both high or both low, the problem is above the gland, in the pituitary. That's central disease, rare, which is exactly why it's tested. Now the second half, if the thyroid-stimulating hormone is abnormal but the free thyroxine is still normal, that's a subclinical state, and the expected answer is almost never to treat on the spot. It's to repeat the test in 6 to 12 weeks and confirm. A single abnormal value is a finding. A persistent one is a diagnosis. Look for the word repeat before you reach for a prescription. Our second strategy governs every medication adjustment question. Rule 1. Wait before you recheck. Thyroid-stimulating hormone is slow, taking about 6 weeks to catch up to a dose change. So when a stem says the dose changed 2 or 3 weeks ago and the level still looks wrong, the trap is to change it again. The correct move is to wait and recheck because the number simply hasn't caught up. Rule 2, change one thing at a time and look for a reason first. When a stable patient suddenly needs a higher dose, the test writer has planted an explanation. Pregnancy is the classic, raising the requirement early. A new calcium or iron supplement is another, because they bind the pill in the gut and block absorption. And poor adherence hides in plain sight. Find the cause, address it, adjust the dose, then recheck at 6 weeks. That sequence is the answer. Now, hyperthyroid drug selection, one of the highest yield pieces because it's so easy to test. First, match the drug to the trimester. Methimazole is your default for nearly every patient, dosed once a day with far less risk of liver injury. Propylthiouracil has two roles: the first trimester of pregnancy and thyroid storm. So the instant a stem gives you a pregnant patient with hyperthyroidism, find the trimester because that decides the drug. Second, know the two adverse effects cold. A patient on either drug who calls with fever and sore throat is not routine. That patient needs a white blood cell count with differential now because you're being tested on agranulocytosis. And propylthiouracil is the one linked to severe liver failure, which is why it's not the default. Third, recognize the overkill answer. Radioactive iodine and surgery are legitimate in the real world, but here they're usually the aggressive distractor for a patient who hasn't had a trial of medical therapy. And radioactive iodine is absolutely contraindicated in pregnancy and breastfeeding. The moment a pregnant patient appears, cross it off. Let's work through our first practice question. A 62-year-old woman comes in feeling completely well, no symptoms, no medications. Routine labs show a thyroid-stimulating hormone of 7.1 above range and a free thyroxine within normal limits. Her pulse is 72 and her exam is unremarkable. What's the most appropriate next step? Before you choose, notice two things: no symptoms and a normal free thyroxine. Read the options, commit to an answer, and we'll walk through it on the next slide. Let's break this down. First, spot the pattern. Her thyroid-stimulating hormone is high, her free thyroxine is normal, and she has no symptoms. That's subclinical hypothyroidism. The values move in opposite directions, so the problem is in the gland, and the normal free thyroxine separates subclinical from overt disease. Second, apply the rule. Her elevation is mild, she's not pregnant, and she feels well. The next step is to confirm by repeating both values in 6 to 12 weeks, because many of these return to normal on their own. Third, eliminate the wrong answers. Starting full replacement treats a value you haven't confirmed, the classic Act 2 fast trap. A radioactive iodine uptake scan evaluates a low thyroid stimulating hormone, not a high one, so it answers a question nobody asked. An ultrasonography evaluates structure, but her exam is normal with no palpable nodule, so there's nothing to image. The answer is to repeat the thyroid stimulating hormone and free thyroxine in 6 to 12 weeks. Confirm before you treat pointed you straight to it. Here's our second question, and it rewards catching a single detail. A 28-year-old woman at 8 weeks gestation reports palpitations, heat intolerance, and weight loss despite a good appetite. Her pulse is 110. Exam shows a diffusely enlarged thyroid and a fine tremor. Her thyroid-stimulating hormone is suppressed and her free thyroxine is elevated. She's never been treated. What's the most appropriate next step? Notice they told you the gestational age. On this exam, that's never given by accident. Pick your answer and we'll work through it. Let's break it down. First, find the detail that decides. 8 weeks places her in the first trimester, which overrides your usual default. Methimazole is associated with birth defects in early pregnancy, so the right agent is propylthiouracil. Second, why the others are wrong. Methimazole is the default for almost every other patient, which is exactly why it's tempting here, but the first trimester is its one exclusion. Radioactive iodine is absolutely contraindicated in pregnancy because it crosses the placenta and destroys fetal thyroid tissue, and it should be eliminated the instant you read gestation. And total thyroidectomy is far too aggressive for a woman who's never had a trial of medical therapy, your overkill distractor. The answer is to begin propylthiouracil. One detail decided the whole question, and that's how these are built. Now, thyroid nodule follow-up, one of the most predictable algorithms on the exam, and testable because most students get the order wrong. Rule 1. Check function before structure. When a STEM hands you a nodule, whether found on exam or incidentally, your first test is a thyroid-stimulating hormone, not an ultrasound, not a biopsy. If it comes back suppressed, the nodule may be making hormone, so your next step is a radioactive iodine uptake scan to see if it's hot. If it's normal or high, you go to ultrasonography of the neck. Function first, then structure. Rule 2, let the ultrasound decide the biopsy. Ultrasonography tells you the size and whether there are worrisome features, and those determine whether fine needle aspiration is indicated. A small nodule with reassuring features gets repeat imaging, not a needle. And plainly, biopsy is never the reflex first step before you've checked the thyroid-stimulating hormone. When fine needle aspiration sits at the top of the list, ask what should come before it. Here's our third question, testing the algorithm we just built. A 45-year-old woman has a 2-centimeter thyroid nodule found incidentally on neck imaging after a minor car accident. She feels well, with no compressive symptoms, no hoarseness, no history of neck irradiation, and no family history of thyroid cancer. Her exam is otherwise normal. What's the most appropriate next step? Notice how carefully the STEM hands you every reassuring feature and denies you every red flag. That's the test writer telling you something. Choose your answer and we'll reason through it. Let's walk through it. First, order the algorithm. Every nodule question begins with a thyroid-stimulating hormone level because that inexpensive test decides which branch you walk down. A suppressed value sends you toward a radioactive iodine uptake scan. A normal or high value sends you toward ultrasonography. You can't pick a next step until you know which branch you're on. Second, the key distinction. Fine needle aspiration is the classic trap, and a good one, because it feels decisive and may be what this nodule eventually needs. But it's out of order, and out of order means wrong. Magnetic resonance imaging is the wrong study for the thyroid and adds cost without changing management, your cost-effectiveness distractor. And referring for a lobectomy before anyone has characterized the nodule is overkill. The answer is to measure the thyroid-stimulating hormone. Cheapest useful test, correct order. Before we close, a test-taking pearl that generalizes far beyond the thyroid. Run every endocrine answer choice through a filter. First, is it confirmed? Before you treat anything, ask whether the abnormality has actually been confirmed. A single out-of-range value in a patient who feels well almost always calls for a repeat, not a prescription. That question alone eliminates the Act 2 fast distractor on many endocrine items, and you saw it work on our subclinical hypothyroidism question. Second, is it in order? Ask whether the answer you're drawn to comes next or comes later. Fine needle aspiration, radioactive iodine, and thyroidectomy are each the correct answer to some question, just not this one. When a choice would be right eventually, the exam is testing whether you know what comes before it, confirmed and in order. 2 questions, and a great many thyroid points. That wraps up thyroid management for step 3. Remember the core ideas. Let the thyroid-stimulating hormone lead. Read together with the free thyroxine because their direction tells you where the problem lives. Confirm a subclinical abnormality before treating. Wait about 6 weeks to recheck after a dose change and hunt the stem for a reason before raising a dose. Match the antithyroid drug to the trimester. And remember, fever and sore throat on either drug means check a white blood cell count today. And for every nodule, function before structure. The best way to lock this in is the endocrine section of your question bank under timed conditions, alongside your review resource, reading every explanation even when you got it right. Visit roadmaptoresidency.com for expert tutors and advisors who can build a personalized study plan. If this helped, please like and subscribe. Good luck on your exam, and we'll see you in the next video.